Chapter 42 begins a 5-chapter series on all the cardiac drugs. These are the glycosides, anti-anginals, and antidysrhythmics. Before we get into this, I think you already had cardiac or should be having your cardiac section right about now. Just want to go over some things quickly. In the beginning of this unit, the first 2 pages talks a little bit about the heart conduction. You should have an idea of this also from your pathophysiology. So when we're talking about these drugs, especially the cardiac glycosides, we need to talk about the heart pump. Your cardiac output is your heart rate times your stroke volume. The strength of that squeeze of the heart results in how much out your heart pumps out with each minute. And then here talking about heart failure, you can have a weak heart muscle or a stiff heart muscle. You see where it's real thick here. There's several different things, or don't have a picture here. There's right-sided failure, there's left-sided failure, and then there's this cardiomyopathy where the muscle is thick or stiff and won't relax. These are affected by your preload and afterload. You'll hear these words mentioned with different drugs, which ones do what. Your preload is obviously the volume of blood going in the ventricle down here at the end of diastole. And afterload is how much the heart has to pump against when it squeezes. This is just a real good thing on congestive heart failure, a little mnemonic on unload fast, because we will talk about nitrates, touch on diuretics, but those will be covered in the next chapter. Oxygen, remember oxygen is a medication. ACE inhibitors will be briefly mentioned, but they are covered more in the hypertensive chapter, I think it's chapter 44. Digoxin is an aminoglycoside, a cardiac glycoside, which we will discuss now. And some other things, APGs, potassium, we'll talk about that. So what are the glycosides? A small group of plant glycosides act directly on the heart muscle. They include, but are not limited to, cardioglycoside. The main cardioglycoside that we will talk about that is used is digoxin, brand name lanoxin. This is important on digoxin. I want you to go to the right side of page 603, talking about digoxin. There's also the prototype on page 604, chart 42.1. Digoxin is a drug to know about. Its half-life is 30 to 40 hours, so it can accumulate and cause a drug digoxin toxicity, which can be fatal. Your therapeutic level is 0.8 to 2.0, so greater than 2.0 is a dig toxicity. 30% of digoxin is metabolized by the liver, and 50 to 70% is excreted by the kidney. Thyroid dysfunction alters metabolism of digoxin, so whether they're hypothyroid, they may need to lower the dose. If the hyperthyroid is functioning too much, they may need to increase the dose. It works by increasing the squeeze of the heart, or the myocardial contraction. This results in an increased cardiac output and an increase of blood circulation to the heart itself and other tissues in the body. It decreases the conduction through the AV node, and so the heart rate is decreased. It can be given orally or intravenously. It inhibits the sodium-potassium ATP phase, right, as you can see here. Prolongs the increased force of the cardiac contraction, resulting in increased cardiac output, and a decrease in the ventricular rate because it affects the AV node. The SA node is for your atrial contraction down to your AV node, which is your ventricular contraction. Note here on hypokalemia, very important to monitor the potassium level, because as the potassium level gets low, below 3.5, it can result in actions like a DIG toxicity. And you see also hypercalcemia, elevated calcium level, aggravates or exaggerates this whole effect on the heart also. This is a good picture on your DIG level, cardiac tune-up. It can be given oral or IV. This says toxic 2.5. Toxic is actually 2. I want you to know the 0.5 to 2. You need to teach the patient, I think it's here, yes, on your nursing process, there's a couple of things on, if you are on a potassium wasting, not a potassium sparing diuretic. Diuretics are in the next chapter. Hydrochlorothiazide, furosemide, common diuretics. You lose potassium with it, so you need to monitor the potassium level when they're on these, and on digoxin. Also cortisone, and if you're on any type of cortisone along with digoxin, it can decrease your potassium levels. Teach the patient to take an apical, not radial. They need to take their apical pulse before they take the digoxin every day. Remember, it's got a 20 to 30 hour half-life, so it is a once-a-day dosing. And your text is 0.8. I'm sorry, ignore this. 0.8 to 2.0 on your drug level. Anyway, taking an apical heart rate for 60 seconds, a full minute. On page 606 is an herbal alert. Several different things affect your digoxin level. Please look over that. Ginseng can make it a falsely elevated DIG level. St. Ort's decreases absorptive DIG. Psyllium, which is Metamucil, which is common over the counter for constipation, may decrease the DIG absorption. Orthin may increase the effect of digoxin. Licorice, this is interesting, can potentiate the effects of DIG, promotes potassium loss, which increases the effect of DIG, leading to toxic symptoms. Aloe may increase the risk of DIG toxicity because it increases potassium loss. Mayhung or ephedra increases the risk of DIG toxicity. Golden seal may decrease the effects of the cardiac glycoside. Digoxin increase the effects of antidysrhythmics. So very important herbal alert there. DIG toxicity is critical. DIG toxicity can present itself with anorexia, diarrhea, nausea, vomiting, bradycardia, because it does block that AV node, slows the heart rate down. Can lead to premature ventricular contractions, which is irritability in the ventricle of the heart. It can lead to many other cardiac dysrhythmias, especially heart blocks, first degree, second degree, third degree. You will get more interrhythms in adult health too. It can present itself with headaches, malaise, blurred vision, visual hallucinations, different colors in the vision, confusion, delirium. The antidote is digoxin immune fab. I always know it as Digibind, but digoxin immune fab. If they are cardiotoxic, the heart is very, very messed up, out of rhythm. They may give phenytoin, which is what you covered recently on your anticonvulsants, and lidocaine, which is an anti-arrhythmic. Note in chart 42.1, caution, acute MI, acute heart attack, renal disease, hypothyroid, hyperthyroid, hepatic dysfunction, bradycardia, and hypokalemia are all cautions, possible contraindications with taking. And of course, if you have a ventricular dysrhythmia, second, third degree heart block, your DIG will have to be held. Although DIG toxicity will cause that, but you obviously wouldn't give it if those already exist. So the next drug mentioned here in this phosphodiesterase inhibitors, I just know it as milrinone. The only drug I know in that class is your milrinone. It is a very, very strong inotropic. Inotropic means it helps the heart to squeeze. It's for acute heart failure. It is given no longer, I think it's 48 to 72 hours. It is given intravenously in a critical care unit to increase that stroke volume and promote vasodilation. They must be monitored in the unit under cardiac monitor the whole time. Okay. If it's given too long, it can cause severe arrhythmias. You see here cardiac arrhythmias. We're going to move on to page 607, anti-anginal drugs, which are used to treat different types of angina pectoris. You should cover angina in your med surg on the different types. You can refer back to this text for different ones for different types of angina. I'm not going to cover the types of angina in this lecture. That should be covered in med surg. Notice there is a table 42.3 going over the different types of anginal drugs, which I also have in the next slide. So the anti-anginal drugs I like this picture. It increases the blood flow either by increasing oxygen supply or by decreasing oxygen demand. There are three types: the beta blockers, the nitrates, the calcium channel blockers. You see here, it dilates, affects the coronaries. By dilating, that increases the blood flow and oxygen supply, relaxing the bronchi, again to increase oxygen supply. It dilates throughout the vascular system. Here, the common drugs, the vasodilators are the nitrates, and the calcium channel blockers. Calcium channel blockers do both. They dilate and cardiac depressant, and the beta blocker is a cardiac depressant and slowing down that heart rate. So the nitrates reduce the venous tone, decrease the workload of the heart, and cause vasodilation. The beta blockers decrease the workload of the heart and decrease the oxygen demand. The calcium channel blockers decrease the workload of the heart and decrease the oxygen demand. This is a good picture with the nitrates. The nitrates do cause a generalized vascular and coronary vasodilation, which increases the blood flow of the coronary arteries to the myocardial cells, reduces myocardial ischemia, but it can also cause hypotension. When it says not to get any of this on yourself, not to touch the medicine part of the patch, it's because it is not selective. It vasodilates all vessels in your body. If you ever get it on you, you will have the most pounding headache. Patients will complain of a headache. They may get used to it when they've used nitro for a while, but they do get headaches with it. I remember we used to try to put it, when it used to be in an ointment, and you put it on this piece of paper and tape it to their body. I got it on myself once, and I thought I'd die with a headache the rest of the shift. Well, for a few hours, because it thankfully has a short half-life. Anyway, you can see prototype 40 on chart 42.2 on 609. It's given by mouth, sublingual. There's a slow release IV, ointment, or a patch. Given under the tongue. You see here taken sublingually. Onset is 1 to 3 minutes, duration 20 to 30 minutes. You give a nitro for somebody with known angina. If it's not relieved with the first, you give a second one and you call a 911. You can give one every 5 minutes for a maximum of 3. It is significant first pass metabolism. which occurs in the liver, so that's why it's best given sublingual, or it needs to be the extended release so it does not get wasted away through the liver first pass. I hit a wrong button there. Okay, so the slow release or sustained release, the only one I know of is isorbide that is given. Your pharmacokinetics, 40 to 50% of nitrates absorbed through the GI tract and inactivated by the first pass, which is why it's not given in an oral route other than that one slow release, the sustained release tablet. So it's given sublingual. It can be given in a spray. Yes, it shows the spray here, intravenously, patch, and ointment. Different ones used for different types of angina, however you want to say it. Adverse effects are orthostatic hypotension. Instruct them to get up slowly. And it acts directly on the smooth muscle of all the blood vessels. So by doing this, it decreases that preload, the amount of blood in the ventricles at the end of diastole. It decreases the afterload. So all of this is so that the heart doesn't have to work as hard. So you can have, due to this drop in blood pressure, you can have hypotension, dizziness, weakness, and faintness. If they're on a patch or an ointment, it should be tapered over several weeks, or they'll have a rebound effect of severe pain and myocardial ischemia. They can also have reflexive tachycardia or heart rate greater than 100, so it has to be tapered off. Lots of drug interactions with beta blockers, calcium channel blockers, vasodilators, and alcohol can all cause a hypotensive effect if taken with the nitrates. Sorry, I have these out of order. We're going to skip over to calcium channel blockers and then come back to beta blockers. I didn't talk about ACE inhibitors. I said we will talk about those in, I think it's chapter 44. Whenever I think of the heart, I always call it the ABCs. The ACE inhibitors, the ACE and the ARBs, angiotensin retention blockers. So the ACE inhibitors, ARBs, beta blockers, calcium channel blockers. That's what I refer to as the ABCs of cardiac drugs. So anyway, into the calcium channel blockers. They are used for stable and variant angina, certain dysrhythmias, and for hypertension. Activates the myocardial contraction, increases calcium activates myocardial contraction, increasing the workload of the heart, so it needs more oxygen. So blocking this calcium channel, see here, block the calcium access, decreases the contractility and decreases the workload of the heart, which decreases the squeeze, conduction, so that decreases the demand. Side effects can be a lower blood pressure, bradycardia. It can lead to an AV block in your rhythm, headache, abdominal discomfort, peripheral edema. Peripheral edema is as you go up on the doses of calcium channel blockers, they will have edema. Edema is due to a decrease in peripheral resistance, which leads to that edema. Table 42.1 and 42, let's see. 42.1 talks about anginas. 42.4 breaks up all these anti-anginals. I talked about your nitrates. Yes, nitroglycerin, isorbide are the only ones really need to know there. Your calcium channel blockers, amlodipine, diltiazem, felodipine, isardine, nicardipine. If you notice something, nifedipine, what do you notice in almost all of these is the pine end of them. dipine, and on almost all calcium channel blockers. Not everyone, but the majority of them. Look over this for the different types of angina that these can be used for. They all seem to be a category C in pregnancy. Everything is PO except for your verapamil, which is the one that's given PO or IV, because it's used for multiple things: angina, dysrhythmias, hypertension. As your text says, the calcium channel blockers, hypotension is more common with nifedipine and less common with diltiazem. They can have dizziness and flushing of the skin. Nifedipine immediate release has been associated with increased incidence of sudden cardiac death. I remember when they discovered that, because years ago we used to take a capsule, poke a hole in it, squirt it under the tongue for hypertensive crisis, and then realized it was actually potential for immediate cardiac arrest. So of course we stopped doing those. Read over your nursing process on all these anti-anginals. Be familiar with it. Nitroglycerin is contraindicated for marked hypotension or having an acute myocardial infarction. Monitoring the blood pressure, sitting or lying down when taking it for the first time, and slowly raising up slowly because of orthostatic hypotension. Not touching the patch. Do not apply nitrobit ointment or transderm nitro in any area on the chest in the vicinity of a defibrillator, because it can cause explosion and burns on the skin. Advise the patient to not ingest alcohol when they're taking nitroglycerin because of severe hypotension, weakness, and faintness. You build a tolerance to nitroglycerin. I forgot to say that before. Over a period of time, that is why when they're on the patch or ointment, they do it for like 18 hours of the day. They take it off at night. Always rotate sites. When they do the sublingual nitroglycerin, they will get a sting under their tongue. It is sensitive to light. It needs to be protected from light, so it needs to stay in the little brown bottle it comes in. It does expire. It's sensitive to heat and light and moisture, so that's why it comes in a little bottle with a tight little top. They should not move it to other containers, and if they take it and they don't get the little tingle under the tongue, it's time to get a new bottle, because the bottle comes with several in them. They never use the whole bottle, and it sits there and it expires and it doesn't work when they need it. So that is a major teaching. Okay, and here we are, the calcium channel blockers. One more thing with calcium channel blockers, it has some major interactions. Do not take it with grapefruit, because it decreases the drug metabolism of calcium channel blockers such as felodipine, nifedipine, amlodipine, verapamil, many of these calcium channel blockers. We're going to move into beta blockers. We just have to go backwards in your chart. In your text, page 608 goes into the beta blockers. This explains how it works. There's beta receptors. If you remember from your sympathetic nervous system, your beta receptors in your sympathetic side. You have beta 1 and beta 2. Different beta blockers. Some are selective, some are not, which will affect choices for when you're using certain beta blockers. They work by blocking the action of the catecholamines epinephrine and norepinephrine, resulting in a decreased heart rate and blood pressure. Never should be stopped abruptly, because there will be a rebound in the heart rate. The selective beta blockers, atenolol and metoprolol, those are the ones that are used for controlling angina. Your non-selective beta blockers, if you think of the beta 1 and beta 2 being your lungs. If you have somebody with asthma, COPD, you do not want to give the non-selective beta blockers because of the lung constriction. Here's a good picture on the side effects of beta blockers: hypotension, symptoms of heart failure, coughing, short of breath, edema, fatigue, drowsiness, depression. and AV block. Your table 42.4 on 610 breaks down your beta blockers. If you notice, they're all metoprolol is the only one that can be IV. The rest are PO. All pregnancy category C. On your pharmacokinetics, the half-life is 5 to 6 hours. On your pharmacodynamics, decreases the force of the myocardial contraction. Oxygen demand by the myocardium is reduced. I told you about the adverse effects of the bronchospasms. Also, the non-selective can cause behavioral or psychotic response. Monitoring your vital signs, tapering over 1 to 2 weeks. Now we're going to move into your antiarrhythmics or antidysrhythmic drugs, page 613. I'm not sure how much you cover this in your med-surg this semester. You will get it very specifically next year, but this is, the heart has a conduction system. Your SA node is up here in your right atrium. It is your natural pacemaker. It sends the impulse to the AV node, which atrial ventricular node, and that sends the impulse through these fibers to get your ventricles to contract. So any arrhythmia or dysrhythmia is when these are off. Here's another slide. It goes into your antiarrhythmic drugs. There are 4 classes that are broken down in the next slide. I don't need you to memorize every class, just to have an idea of the different drugs and how they work. So there's the sodium channel blocker, the potassium channel blocker, digitalis, digoxin does its own thing, calcium channel blockers, beta blockers. So in this slide, it breaks it for you with the sodium channels, moderate decrease in part of the depolarization. You can have a QT, can be prolonged. These are the drugs, quinidine, procainamide that go with it. Then more, these are all sodium blockers, so all the class 1 and the different kind that go with it all affect the depolarization phase of the heart. So phase 1, class 1 depolarization phase prolongs it. And these are the kind. So your class 2 that block the adrenergic beta 1 receptors, resulting in a decrease in the heart rate, AV contraction, that's from the atrium to the ventricle. It decreases the ventricular automaticity. That means the ventricle, if it has its own little pacers in there firing off, it blocks that irritability and the ventricle from being able to pace itself and cause these erratic and sometimes fatal dysrhythmias. Increases your PR interval, which is your atrial contraction, which can have to watch for potential of heart blocks. So your propanolol, esmolol, if you notice the alol are the beta blockers, and there's a potential not to give beta blockers when they have some kind of prolonged PR interval, some kind of heart block, whether it's first, second, or third degree. Your class 3 are your potassium channel blockers, prolongation of ventricular repolarization, that's your QT interval. If I go back to here, this is your P is your atrial contraction, your QRS is the ventricular contraction. I'm going to go over here, that's your QRS, your T, this is your T wave, so your QRS. So from the beginning of this upward thing, your Q to the end of your T, which is your contraction, your impulse coming through your ventricle, and repolarization is this ventricle relaxing and trying to get ready to fill and fire again. So it prolongs that QT interval, and that's many drugs will prolong that, and you have to watch for it. So amiodarone is the most popular one as far as being used for that. And then your class 4, which blocks your calcium channels in your SA and AV nodes, which is your diltiazem and verapamil. I'm just glancing through here to see if there's specifics that you really should know. We've talked about beta blockers already. Drugs in class 3 are for emergency treatment of ventricular dysrhythmias. That's amiodarone. The refractory time, giving the cells time to relax to prevent them from going into like VFib and VTAC. Talked about calcium channel blockers earlier. Side effects for antidysrhythmics. Quinidine has many side effects: nausea, vomiting, diarrhea, confusion, hypotension. It can cause heart block. It's not used that often anymore. Lidocaine, where is lidocaine? On here, right up here. You can get a lidocaine toxicity, so you have to be careful. They do use it, but not give as many doses as we used to do. It can cause cardiovascular depression, bradycardia, hypotension, seizures, blurred vision, and double vision. Contraindicated in patients with advanced AV block. Used with caution in patients with liver disorder and heart failure. All dysrhythmic drugs are potentially pro-dysrhythmic, even though they're there to stop dysrhythmias, or they can actually stimulate more dysrhythmias. Some cases, life-threatening ventricular dysrhythmias can result from appropriate and skillful attempts at drug therapy to treat patients with heart disease. Look, with prototype 42.3, acetobutol, I wouldn't know specifically that, just that you're monitoring your liver enzymes with these antidysrhythmics. Look over your nursing process, baseline EKG, monitoring cardiac enzymes, your vital signs, looking at your PR, your QT, all your conduction delays, and on your side effects, advise patient to avoid alcohol, caffeine, and tobacco. Alcohol can intensify hypertensive reaction, just like it does with digoxin also, which is also used for rhythms. Caffeine increases catecholamine level, and tobacco promotes vasoconstriction. And that is the end of chapter 42, and then continue on in the lecture for chapter 43 on diuretics.